Dr. Vivek Gupta. After that, Manish sir, and now that will be the last whole thrombectomy. And after that, we'll finish our last presentation of innings 3. So over to you, Tariq. You can start.
Good evening, everyone. So it's really been extended monsoon here in Delhi, and we are having extra innings there. Past 3 days was raining heavily here, and almost half of the city were deluged. So we'll go with. Am I audible clear?
Yeah, 100%. You're
okay. And I have to finish in 20 minutes or some. What's my permitted time? Okay, so if I am audible, I'm going ahead. So I will be talking about basically the imaging sequences. It's not a novel.
Yeah.
It was there long before, but we say novel because we were using it for the first time, and it was the necessity, the situation. So the circumstances made us to do those things.
The data is
next slide is okay. I'm not able to go to the next slide. Okay, this one. So disclosure, not doing diagnostic radiology, not an expert in diagnostic radiology. Still for past more than a decade or more than that, I have been just pursuing this vascular stuff. So I'm not an expert. So there may be many things which on a diagnostic aspect would not be a thing, but these were the two imaging modalities which we used. The first is the arterial spin labeling. As we all know about the extended window time period, we moved from time to tissue window, from the functional window, and then there was a necessity of getting a CT perfusion. And as our center was there, it was more on a drip and ship model, and most of these patients, the time they landed up 6.5, 7, 8 hours, and the imaging we try to do a CT perfusion, MR perfusion, was not able to get it done at the mid of night, patient moving, to get just a perfusion imaging to get the idea of a viable or the viable tissue or the tissue at risk, we need to do something. Then, as we all know, the diffusion negative and perfusion positive tissue, that is what we need to find out. And diffusion lesion was very straightforward, but finding out the perfusion positive was an issue with our setting. So then we embarked on a journey, which we say about an ASL thing. We started this, I think, a couple of years back or less than that. So all the perfusion measurements, they need a tracer agent, whether it's a contrast or whether it's the nuclear spin. So here, when this, I would just like to say this, we started.
Tariq, sorry to disturb you. Go to the full screen view because we are seeing your smaller. Yes, please.
Is it now?
No, that is no view.
Sorry, this is not my laptop. This is Sanjeev's laptop. So I'm not.
So
can I please?
On the top rightmost, you can see you slider show something.
Yeah. Is it not? Is it all right?
A little bigger, but still not the full view.
But in Sanjeev's laptop, this is fullest. It will go beyond Sanjeev's laptop then.
Yeah, now you can go to the full view.
So that's better.
Right.
Okay. That's better. Okay.
No, rightmost, you can see the full presentation. Yes, that one.
Yeah. I'm not used. Sorry, my apologies. I'm not used to Mac. Yeah. Is it all right? Yeah. So we need a tracer for perfusion measurement. I was saying it may be contrast or it may be a nuclear spin. And this ASL we picked up a couple of years back because I was traveling to Calicut for these proctoring cases at Calicut, and there one of our friend, they were using the department was using an ASL lot, and they told us, why not you are using an ASL for your extended window period. So this has been hovering around this sequence since 1990 in its infancy. It was not developed because the contrast, the signal to noise ratio was not adequate, and with an advent of 3T and further some developments, we were able to get good images. So the basic theory is that we label by a continuous pulse or the pulsed or a pseudo continuous pulse. So these are the three things. I would just go back. So here we do a labeling just at the neck of the water in the flowing blood, and then that labeled blood spin is going inside the parenchyma and coming out, and then the calculations are done to find out the cerebral blood flow. CBF map just comes with a spin labeling, and this sequence what we have used, we were trying to optimize it because of the significant contrast thing, and the most important thing was about the time, the delay, the pulse delay with what we have to give. We started with 1500 milliseconds, then increased to 1800 to now we have got it to 2000 milliseconds. I'm not expert, again I'm saying I'm not expert on this we just discussed with our diagnostic radiology people and from the Philips application guys, and 200 is now what we have set for most of our assessment. So this is a continuous leveling, and this is a pulse, and this is the delay which is there. So what are the limitations? Yes, probably they got a low SNR. Overall reduced CBF to a vascular territory, that is not attributable to true reduced flow. We are overestimating. So in my simplified view, it is like a TOF compared with the contrast MR angio. You are overestimating because the time, the pulse which is being given till the time it comes out of the thing, that blood, the hydrogen ions get remagnetized, and what you are able to see is not a true perfusion deficit. It's more than what was expected. So in that aspect, as I was telling, we try to increase the milliseconds of the PLD, the delay, and we were able to get a significant amount of good SNR. That was the as you increase the delay, the SNR goes down. That's what the application guys told us. So because it was a contrastless thing, we can, if the patient moves during these things, we can again repeat it. There is no wastage of contrast. We can again repeat it. The things we can keep on doing the things that till the time we can reduce the field of view accordingly and say, okay, just we need this limited information. Since 2000, this ASL has been incorporated. Multiple studies have gone. 2012, there were a comparison study with the T2 perfusion, and they found it okay. It's doing pretty good, or pretty okay. And then they said, okay, then further things needs to be done. But yes, it can be utilized. Or with the 3T, the studies which has been mentioned here shows almost 90% correlation with a T2 weighted perfusion. It was with 1.5, it was 60%. Just to a case, straightforward case, extended window period, left MCA evolving stroke, and we used, this was our first case of Sophia, there direct aspiration, and this was the CBF map which came to us. We said, no, we have to go ahead with this. We can't leave this patient. There is a different, the diffusion volume is lesser than what has been expected, even if it is overestimating in the CBF map of ASL. And we did, and the patient did well. Straightforward case. Another, but always the life is not that thing. This was a case where 47-year-old, this video plays on Sanjeev's laptop or not. Let's see. This was the diffusion. Sit. I think, yeah, that was playing something. Yeah. So that was a diffusion image, the video of the diffusion image taken, left MCA stroke, and that's what is the corresponding the ADC map, which will not go into that. We'll go into the thing. Yeah, regarding the clinical aspect of this case, this was a wake-up stroke. Somebody thought it is a 7 hour, somebody thought, no, we have seen that guy. This was a young guy last seen. So nobody was sure about this thing. And when we got a flare thing, this landed early in the morning. And when we did a flare thing, the flare was not showing much of a change. So there was even flare diffusion mismatch. And then we did also the ASL, and the ASL was showing a deficit, a significant deficit there. We all are very active unit in stroke, and our neurologist is also quite active. So we all want to extend beyond our limits. So he said, no, I'm going to thrombolyze this guy. This comes in an extended window period, and this, even if it is a wake-up stroke, there is a flare diffusion mismatch, and he went ahead with the thrombolytic therapy until the time we arranged the cath lab, and this was the MR angio, obviously the left MCA occlusion, right MCA occlusion. Till the time we took up the first angiogram, what we saw was, to our disappointment, oh, it has recanalized. We have got nothing to do. But on a closer look, we saw, no, there is one of the vessel which is not. And probably this is supplying the motor cortex or the thing. So we went ahead with this. We used a Catch Mini device and do a MeVO, and we opened that vessel, and that was the clot which was taken. So yes, it has helped us in extending our spectrum. It has helped us in including more and more patients. Just a word about this, the superior division MeVOs. In my experience, what we were earlier using was a preset light. Even they are 420. We have got, I think, 2 of the devices which go by 017. That is preset and preset light, and the Catch Mini. The preset light, whenever we are doing in a superior division along the convexities, whenever we are pulling down the device, we have observed in our expert CT the some amount of the subarachnoid hyperintensity is more rather than with the Catch Mini. The Catch Mini are more softer than, that's my opinion, the Catch Mini is more softer than anything. So this was, again, a good experience. But there are certain times where this was a 94-year-old lady lying somewhere in the casualty of a big thing referred to us. When she came to us, it was almost more than extended window period. The diffusion volume was not that big, but a left MCA occlusion, and we did the ASL. The ASL was showing a, I think this is not a video. Okay. So the ASL was showing a diffusion perfusion mismatch. This was a time when we were doing an ASL. This was 6 months back, where we have not optimized our the PDA values. The values were around 1500 or something like that. One of the attendant of the patient was a medical doctor. She persisted, not he, she persisted. No, we need more evidence that you want to go ahead with a thrombectomy, you want to salvage. So just to convince her, we did a T2 perfusion also. And what we found, the ASL was overestimating in this. This was the upper picture is a T2 perfusions, the CBV, that map, the CBF map of the thing, and it was an overestimating thing, probably because then we called our the application specialist, and we discussed this thing about the ASL discrepancy, and we increased the values and things. Still, we are evolving. We have not yet come to a point where say we are completely okay with our values. Still, we are evolving. So there was a significant discrepancy, and we left that patient. We didn't do anything. And next day the MR follow-up MR, the stroke did not increase, and then we repeated a CT a week later, almost a deficit, and the things were almost, we do not do an angiogram, DSL, the catheter angiogram in this patient. So sorry. So then there are certain times where we have even, it's always not an act of commission. Sometimes it was an act of omission also. This was a patient, PTCA was done in hospital, and the patient developed a weakness somewhere at around, the deficit was there some in the 7 in the morning, which was categorically noted by the nursing staff there. She said it's 7. I am pretty sure 7. And 8:30 the alarm was raised. Till the time we were gathering for the thing, because the patient was post PTCA, the obvious thing was, yes, we have to do a mechanical. Till the time we got the image, this was because till the time we reached the hospital, everything was done, and this was a no perfusion diffusion mismatch, and we did not intervene. We did not do any MEVO and nothing. So these were the two cases where we, even an act of omission was done, and a 94-year-old, and this post PTCA case. Quickly moving on to the second thing, that's a vessel wall imaging, ICAD and ischemic stroke. Again, this was born out of necessity, because we were dealing more with an ICADs, and we were being able to give the answer to these patients, when to intervene, when not to intervene, when to have a thing. So, and we are all aware about this Sampress, and then the V, when the arm was having a significant the 14.7% was in the stenting arm, the 30-day stroke rate, which we've decreased, but yes, still it's there. So we moved on to a imaging known as a vessel wall imaging. This was a 2012 paper by an American Society of Neuroradiology, where they said, okay, no, we have to develop this sequence more and utilize it more for deciding our patients. So the patients, we started using this vessel wall image. We have in fact incorporated vessel wall imaging on all our ICADs, all our assessments of these things. We rely more on a multiplanar 2D acquisition with the 3D. For somewhat reason, we are not getting a good 3D sequence. Oblique planar 2D sequences with the Vista sequences and the PD sequences are the mainstay of our things. And these are the things which we deal. It helps us to differentiate between a plaque, a vasculitis, a dissection, the RCVS. These are the things. More of our thing is to differentiate between a narrowing, what it's the reason for the narrowing, and when to intervene or not to intervene. A decision to intervene or not to intervene, on when to intervene. So has come to help us in an aid of doing an angioplasty with plaques who will benefit from the stenting versus medical management, and for the trials. And the imaging markers of the biomarkers of the ICAD, the vessel wall enhancement, the intracranial plaque enhancement, strongly correlate with the ischemic stroke probability happening with those ICADs. So the vessel wall thickening and the arterial wall remodeling, the outward and the inward remodeling, which happens with an ICAD thing. The components on the intracranial atherosclerosis is more well visible with we can study the plaques. They are too small for these distinct features. And the thing. So the threshold for the stenosis, again, the threshold for the stenosis is there. So it has been to identify symptomatic non-stenotic disease of the intracranial arteries, to determine the location of the atherosclerotic plaque relative to branch ostia, which is a very important thing. Recently, a couple of days back, we did this case where we had, it helped us in assessing those things, and to assess atherosclerotic plaque activity. Is it a hot plaque to intervene, or we can wait for time? So going with the case, 54-year-old male patient with a recurrent stroke in right ICA territory. So as we all know, this plaque imaging, they started with the carotids. It started with the carotids, and then we moved on, because the intracranial vessels are the small, surrounded by the CSF, and to get a good blood suppression images, the black blood imaging in those with a good wall thing was not so. This was our first of our cases where we started doing for the carotids. The male father of a doctor, a pediatrician, who came to us having recurrent strokes, and the MR angio was not showing a significant lesion, and they were being he was being managed conservatively, but still recurrent stroke. So he was shifted from a clopidogrel to Brilinta, ticagrelor, but still having recurrent stroke. And just the MR angio was done. Then somebody did the base images of MR angio was never evaluated. They just went ahead with the VRT images and the volume images, volume rendered images. Somebody did a Doppler, and they found no, the clot is not that insignificant. It's something there which was again re-evaluated on the base images, which said no, it's not looking like that benign as it was seen on that thing. And then we did a vessel wall imaging. It's a T1 plane where we got a significant amount of T1 hyperintensity. So it's suggestive of an IPH. And even in fact, in the vessel wall, in the post-contrast images, we can see the lining, the ulcerations there. So it was a highly unstable plaque. And with the triple protection, because he was having, despite changing the anticoagulation, he was virtually on a triple therapy, 2 antiplatelets plus an anticoagulation, recurrent stroke. So we went ahead with that plaque morphology with a triple protection, where we used a balloon guide to have the flow arrest, attach it to the aspiration system, and then put a filter, immediately pass the device and put the filter up, and then we went ahead with the stent. So again, not looking very ominous on that thing. This was the thing. This was it with a triple protection, and we did, and this was almost done 6 months back, and follow-up MR, and this guy is doing pretty well. So the vessel wall imaging, as we all know, was of significant help to us in the extracranial circulation, but for intracranial, it was a real challenge because of obtaining this thing. So we'll go to another case where we have got a thing, left M1 stenosis, left M1 stroke, which is there thing. And we did a vessel wall imaging. You can see a T1 hyperintensity there, which is not on contrast and non-contrast hanging plaque there, and T1 hyperintensity. So it's a plaque which has probably what we saw from that has ruptured into the lumen and caused the thing. So we used to put the patient on an aggressive medical management. Patient stabilized, but also didn't have any further didn't have any further deterioration. And when we repeated, there was so patient was discharged. You can again see that plaque hemorrhage there, which is seen there, almost a hanging plaque of obliterating the lumen. And when we repeated it after 3 months, that T1 happened, it is gone, and the patient is still managed on the medical therapy. Is doing pretty good. So this was the MRI after 6 months. MR angio repeated after 6 months, was showing a decrease in the stenotic part, and still there is an ICAD there, but the flow is pretty good as compared to the MRI which was done 6 months back at an acute stage. So we didn't intervene on that. This was an interesting case, multiple lesions, multiple thing, and the patient was having, in fact, bilateral carotid stenosis, not just the right was completely occluded, the right vertebral, and bilateral carotid stenosis, 71-year-old male. Mostly it was looking like a posterior circulation symptoms, but we were not sure. We tried to do diffusion again. I think the video is not loaded on this. The diffusion was not showing any abnormality on that. And this was the bilateral carotid stenosis. And we see a vertebral lesion down below and up here. And what this vertebral was completely occluded, and bilateral carotids were down. So this was the angiogram we did, and then we even did a perfusion study to find out where is the perfusion deficit. deficit was more, again, the video probably is not loaded, was seen more on the posterior circulation. We did a vessel wall imaging, the occluded vertebral, and this is the flap, which was very well evident on the V1 segment, the mid V1 segment of that thing, which shows that we probably are dealing with a dissecting segment. And when we moved, and this is the segment which was evaluated, and very well seen a flap there. And when we moved up the intracranial circulation, whereas the artery pierced the dura, again, that's a location where the vessel wall imaging shows artifacts where the artery pierces the dura. You can have an abnormal enhancement there, but our repeated sequences up and down we see, and the plaque hanging there with an ulceration there and obstructing the lumen. So we started this thing. This was the thing. The carotids was also evaluated, and what we decided to do a vertebral plasty. So we did a vertebral angioplasty, the up segment and the down segment with a coronary stent, and the upper segment with an enterprise stent. I think this was the lumen post. Yeah, so this was the left V4 angioplasty which was done with this was an enterprise which was put, and the lower down a coronary stent was put down there. So in this, these two imaging sequences helped us to find out the real culprit, and we were able to find out with the vessel. Another case, we'll just finish off with the cases. Right MCS stenosis with an ICAD. In fact, in using these sequences, we have, even for a non-stenotic lesion, we have been able to characterize ICAD, which in this part of the world, we all know that we have got more prevalence of an ICAD, and the always with the just looking at the VRT images of the MR angio or the CT angio, we are not able to subtype the stroke and give an adequate therapy. This was one of the thing where we did a DSA and got a 70% stenosis, and in this we have got a positive remodeling, which was well seen on this thing. So we have asked the patient to be on positive remodeling is a predictor of an high progression of a stroke, but this is not the time to intervene. We ask the patient to be on the double antiplatelet medical therapy and reevaluate again. Last of my case where we have erred, where this was a young male, right MCS stenosis. The DSA was done, was put on a double antiplatelet, still having recurrent strokes. This was in a stenosis. Even the DSA was done at outside. It was more or less looking like an eccentric plaque sitting under the undersurface of the M1 segment, just short of the MCA bifurcation, involving one of the major perforator from the striate arteries. That was the angiogram. Unfortunately, I don't have that angiogram. And then we evaluated this. Okay, we said, let's do a vessel wall imaging. The patient, we repeated. So this was the previous MR angio. This is the MR angio done with us, both done on a 3T. And we repeated the vessel wall imaging. On a sequence.
Sorry to disrupt you. For time constraint, if you can finish in next.
Yeah, I'm just, this is my last case, Nishan. So, okay. So this was the thing where we did a thing and we got a concentric enhancement in this. So we thought this was the concentric enhancement, and we thought, oh, probably young male, but ESR CRP was normal. There was not any inflammatory markers, the UNCAS and everything. The inflammatory markers were good, and still we thought not to intervene. Put on a medical therapy of immunosuppressant. We restarted with the steroid, and we repeated the imaging after IV pulse steroid. So this was the after steroid. A reduction probably was there, and we thought, okay, we are dealing with, but this patient was still having a recurrent symptom. So we went ahead and this was a credo stent which was put, and at the moment till we put a credo stent, we were quite confirmed we were dealing with an ICAD, because the moment we put the stent, we didn't dilate it with the balloon, because there was a big perforator coming down there, and we don't want to snowball the clot there into that perforator. There was a bigger perforator, so we just put the credo there, and the moment we put the credo, the clot migrated from there, and we had a distal embolism up above, which fortunately for us, because we were in the right territory, number one, and the second was we were able to manage because the patient was already on a optimum medical therapy. So we just underdosing of the GP2Bs, we were able to dissolve those clot, and the patient woke up well, did well after the procedure. So I would just like to end my talk. Thank you for bearing with me.
Thank you, Tariq. We'll take the question answer at the end of presentation.
Sure.
Yeah.
If I'm there.
Dr. Vivek Gupta, are you around?
Yeah, I'm here.
Are you ready?
Yeah.
Please share the screen.
Okay.
So his presentation is Tale of Two Carotids. And for the time constraint, we'll finish it faster because we are having one more presentation after you. Thank you so much. All yours.
So I guess I'm not going to take much time. You guys are already hard pressed for time. So this is actually leftover presentation of the complication meet. So there is no text. This is just a presentation of two carotids. So what happens in day-to-day practice is that we deal with complex cases of aneurysms and stroke, and carotid is something which we do as a matter of fact, and we don't think much about it. And it's a relatively short and straightforward procedures. But sometimes when you're doing it long enough, you do get some cases which makes you think twice. So these are the two cases. The first case is 54 male who was having a typical history of carotid stenosis, repeated TIAs, one of them showing a small infarct. Came for stenting, already evaluated outside critical stenosis, and he already was on low dose aspirin. The previous history that he had a CABG 14 years back, which means he was pretty young when he had a CABG, and he had a non-healing ulcer in the left foot. He was a diabetic and hypertensive as well. So he was planned for like a stenting. He was loaded as per our protocol, and he was taken. And these are the images. Pretty tight stenosis just beyond the carotid origin, but in intracranial perfusion was quite okay. AC was not filling. Procedure was done as per the standard procedure. Lesion was crossed, filter was placed, and pre and post, once the position was confirmed, pre and post angioplasty was done, and stent was deployed. So till this time, there was no problem. It was a straightforward case, finished in 20-30 minutes. And once after, generally, as everybody waits, we also wait for around 20-25 minutes after the procedure is done. And we started seeing the clot in the ICA where the residual stenosis was there. So we thought it's fine, this clot can form, and we know that how to deal with it. We increase the perfusion, we increase the blood pressure, gave some more heparin, checked the ACTs, gave a abciximab. So doing all these maneuvers, just before doing all these maneuvers, we placed a filter just in case that this clot dislodges. And we did all the procedures which we usually do. But this patient was surprisingly resistant to everything. And in spite of giving everything, if you can see on the right side, a large clot is forming at the region of the ECA, and in the mid part of the ICA, this clot is increasing. So we did manually aspirate. We cleared the LICA. Left ICA was clear. So we thought we'll stop it here. But then we noticed that this clot in the ECA origin was projecting inside the internal carotid artery. So in trying to retrieve this clot, we blocked the we dislodged the clot, which blocked the filter, and the left ICA got fully occluded. So we removed the filter, ICA was fine, but this clot, which was there in the left ECA, has now started propagating inside the ICA. And this particular patient was resistant to whatever we were giving, be it GB2BA3B inhibitors, be it heparin or other measures. So again, we had to place the filter. We did clot maceration, captured the clot in the filter, and took everything out. So end result was fine, but we were not sure why we had this in spite of the standard protocol which we are following for past 13-14 years. CT was relatively okay, and 24-hour CT showed a small SCH, focal SCH in only one of the sulcus and a small clot. But thankfully, the clot was in the territory which was a relatively safe territory. Follow-up imaging showed the patency of the ECA and ICA both. And this is a 1-month follow-up CT. Patient survived without significant deficit. He just some cognitive deficits. What we didn't realize was when we did that, which we didn't came in the history, was that patient was smoker. He had not stopped smoking. This is a misprint on the slide. And he was a vasculopath. That's why in the age of 50, he had a triple vessel disease. He had a non-healing leg ulcer. And in addition to that, this is my presumption that he was resistant both to clopidogrel and maybe to somewhat aspirin also. And that's why he was having this repeated. Okay. So this was one case, which is not a very infrequent occurrence. Which is not a very infrequent occurrence, but when we don't pay much heed to the history, then we can land up in such kind of trouble. So this patient was shifted on Brilinta and he's doing well now. So this second lady was again a very typical case, repeated TIAs, critical stenosis, nothing on CT, very, very small infarct on DWI, which was done 2 weeks back. We took for stenting and see this, there is a tight ulcerated lesion at the LICA region. Again, nothing out of ordinary. Again, procedure was straightforward, same protocol, different filter, but filter used, angioplasty done, stent placed, and this was the final image. Nothing abnormal in this. And actually this procedure finished in some 20-25 minutes, and we did the mechanical, we thought we'll do the per close closure. But a fellow was doing it and somehow the knot slipped and the mechanical closure at the puncture site we could not do. So we thought, okay, fine, this happens and we'll do compression and this will settle. So we wheeled the patient out in the post-op area of the cath lab and we did the manual compression. But this manual compression, even after, we kept on doing it, and even after 2 hours, it did not stop at all. It was gushing like anything. Whenever we removed the compression, it was just pouring out. So we checked the ACT. ACT at that time was 650. So we thought that the machine is wrong or somebody has done it wrongly. It's a contaminated sample. We checked it again. The reading came out more or less same, 550 or so. So there was almost 3 hours had passed by this time. So we reversed the heparin according to the standard protocol. And we continued compression, but this bleeding would not stop. And a hematoma started forming. We thought something is wrong. Maybe we had damaged the femoral while doing per close. We wheeled the patient to the CT room, did a CT angio. There was no trauma. There was just a leak at the puncture site. There was no pseudoaneurysm or no dissection. So we thought there's nothing wrong in that. Procedure was also very clean. We did not understand what was happening, but we still did have to close this. Already 2-3 hours, 4 hours had passed. So we again wheeled the patient back to the cath lab and did a covered stent straightforward, and this thing stopped. So till this time, almost 4 hours had passed. Patient was hemodynamically stable, neurologically okay. But while on the table, she started complaining of headache, and there was responsiveness from M6. She was dull M6. So again, we had to take her back on the CT, and this was the CT. There was a bleed, basal ganglia, and you can see the fluid levels. That means something is oozing there. At this point of time, heparin was already reversed. Stent was in situ. There was not much we could do. Patient was relatively stable. GCS was E4. She was just dull M6, nothing else. So we observed the patient. We checked the ACT. ACT had come back to around 220 or 210. But within 2 hours, patient had a massive ICH. Not the massive ICH, that ICH increased. Patient coned, and we lost that patient. So we really don't know why this patient had such a devastating course, why the ACT was sky high. We did this fat analysis, we checked everything. The only thing which we did different was in this particular case, the heparin was not given by us, heparin was given by the anesthetist. We don't know, it's very difficult to predict, but that was the only different thing we did. So maybe the dose was more, or maybe something we missed. I don't know the real reason. But these were the two complications which make us think that carotid stenosis, though a very, very simple thing, but sometimes it lands you into a lot of trouble. And I was reading a book by this Dr. Adam, and these 3 points, that taking history is the most difficult but most important. The simple things go wrong more often because you are not applying brain there, you're doing it at more of spinal level. And the most difficult thing is to know when to stop an operation, because in the first case, I could have stopped when ICA was open and ECA was patent. Maybe we could have stopped that small stroke. Thank you, everybody. Nishant, all over to you.
Thank you. So we'll take the question at the end of third presentation. So please be around. Thank you. Uday sir, you are around?